3, 2, 1. We are live.
So good morning, everyone. So we are back with our another journal club, this time on a very interesting topic about radial neck fractures in children, current concepts. And we have with us Dr. Sandeep Vaidya, with a very senior pediatric orthopedic surgeon practicing in Mumbai. Sir will be discussing the current concepts regarding radial neck fractures. And then we have a few interesting cases on different types of radial neck fractures and its management. So without wasting much time, I would invite Dr. Sandeep sir to please start his presentation.
Yeah, good morning, everybody. Thanks, Maureen. Thanks, Gaurav, for having me here. I'll just share my screen. So I think this is a wonderful initiative which is being run by Maureen and group to have this, weekly session. And yeah,
Sandeep.
So starting off with radial neck fractures, and we know that radial neck fractures are quite rare in children. Okay, in fact they comprise only about 8% of all elbow fractures in children. Suprachondral fractures and lateral condyle fractures.
Can we hear Sandeep loudly enough?
Hello.
Sandeep, थोड़ा loud करना पड़ेगा मुझे लगता है. Gaurav, can we hear him?
Yes, sir. I can hear him loud and clear.
ये मेरा ही लफड़ा है क्या?
And there is some background noise coming from.
Yeah, I've asked everybody to mute.
Tell me when we are ready.
थोड़ा तेरा वॉइस है ना, थोड़ा ज्यादा करना पड़ेगा. देख ना तेरा सेटिंग में तो कुछ ठीक है.
1 minute. I'll just go to the audio settings and see what is happening. How is it now? Better?
No, it is better. Yeah. Now we can hear you clearly.
Okay. So these are rare fractures. And when we see a radial neck fracture, the first question that we need to ask is what is acceptable? That is this fracture, can we just apply a cast in situ and allow it to heal in whatever position it is? Or do we need to reduce it? And for that, there are two questions that we need to ask ourselves. What is the angulation and translation at the fracture site? And what is the age of the child? So obviously, if the child is a bit younger, we may tend to be a bit more lenient in terms of reduction. Now, these are two classification systems which have been described. One is the Jude classification and the other is the O'Brien classification below. But both of them take into account the angulation at the fracture site. And generally, it is accepted that any angulation more than 30 degrees cannot be accepted and needs to be reduced, needs to be close reduced. The reason for this being that when the angulation of the radial neck fracture, it exceeds 30 degrees, the center of rotation of the radial head becomes eccentric, thereby resulting in cam impingement at the proximal radioulnar joint and also resulting in incongruency at the proximal radioulnar joint, thereby reducing the pronosupination. So any angulation less than 30 degrees, we should attempt to reduce and get it in an anatomical alignment. Now, when we talk about the methods of reduction, the most preferred methods of reduction are close reduction techniques. If the close reduction techniques fail, then we may go ahead with minimally invasive maneuvers. And finally, as a last resort, if none of these work, only then open reduction should be resorted to, because as we will see later, open reduction is associated with complications and stiffness. So first, let us talk about close reduction methods. And close reduction methods, these are some of the methods which have been described in literature, the Patterson, Jeffrey, almost 6 or 7 different methods have been described. And in the end, what we will describe in more detail is Moline's technique. And we will come to each one of these in a moment. Now, the basic maneuver that has been described, this was described sometime in the 30s or 40s, is the Patterson maneuver. And it is a simple maneuver in extension and supination, where the assistant holds the arm the surgeon gives traction and virus, and with thumb pressure pushes the displaced radial head into position. So this is a simple Patterson maneuver that was described in the 1930s. Jeffrey came up with this method in 1950, and it just adds one more step to the Patterson's maneuver. That is, what they do in Jeffrey's method is they correctly identified that when a displacement occurs in the radial head fracture, it is not exactly in the AP plane, it is in the oblique plane. And therefore, what Jeffrey described is to pronate the forearm till the radial head is seen in the perfect AP profile. That is, the radial head should be seen as is seen in this X-ray, like a rectangular box rather than an oval ring. So you should pronate the forearm, convert that oblique deformity into a bang anterior-posterior deformity, and then repeat the Patterson's maneuver. That is the Jeffrey's method. Then came the Neher-Torch method, which was described in 2003. And what these authors, they recognized is that when there is a radial head fracture, many times the distal radial metaphyseal fragment is displaced medially. And therefore, in addition to the steps that are described in the Jeffrey's and Patterson's maneuver, what the Neher-Torch method described is that the assistant should push the distal radial shaft fragment laterally. So you push the radial head fragment medially, at the same time push the distal fragment laterally, and that would help to bring your radial neck fracture into correct alignment. So that is the Neher-Torch method. Now, all these methods were described in extension. However, Kaufman in 1989, this was the first method which was described with the elbow inflection. Kaufman method, by the way, is also known as the Israeli method. So what this method basically consists of is that the elbow is flexed to 90 degrees in full supination, and then while applying thumb pressure to the radial head, the forearm is gently rotated into pronation. And so with this, the radial head is pushed back into the correct alignment. So Kaufman's method, remember, it is a method described in flexion and pronation and thumb pressure on the radial head fragment. One of the more recently described methods is the Monson's maneuver, which was described in 2009. And what these authors, they recognized that when the elbow is flexed to 90 degrees and rotated into the full pronation, the apex of angulation at the fracture site, it moves anteriorly. And thereafter, once it moves anteriorly, what happens is that the radial head is fixed in position by the taut ligaments and the capsule. And all that you have to do is push the distal fragment posteriorly, dorsally, which would then help in reduction of the fracture. So the advantage of this method is that the radial shaft, being a longer lever arm, it becomes easier to push the fracture into correct alignment. So rather than pushing the radial head over here, you are pushing the radial shaft over here. And then finally, coming to, I think this is a very elegant maneuver which was described by Monin in 2020 IGO, it was published. And what I like about this method is it combines 2 or 3 techniques, and also it is based on a sound understanding of biomechanics of the proximal radioulnar joint and makes use of the ligamentotaxis principle. So let's go through the steps of this maneuver, and at the end of this talk I would definitely love if Moline could give us some more nuances of this maneuver. So in this technique, what the first step is that the elbow is held in extension and supination. Then varus pressure is applied at the elbow and thumb pressure is applied on the radial head in an attempt to push the radial head medially at this. And then while maintaining sustained pressure, the elbow is flexed and pronated in order to get the radial neck fracture into correct alignment. Now, how does this technique work? So basically what happens is when your elbow is extended and supinated, your capsule, your lateral capsule, posterior capsule, as well as the lateral collateral ligament is lax. However, as you flex and pronate the elbow, these structures become taut. They exert a ligamentotaxis effect at the fracture site, and thereby the radial neck fracture is pushed back into the correct alignment. One important thing about here is that since your capsular ligamentous structures are getting taught in pronated rather than supinated position, the post-op immobilization should be in mid-prone position. So this was the the animated video which I will just play it again so that you can have a look. So it is initial extension, supination. The forearm is rotated so that the radial head is seen in exact AP profile. Then varus force is applied. Then with thumb pressure, the radial head is pushed medially. And while sustaining this pressure, the elbow is flexed and pronated so that the capsular ligamentous structures, they tighten and push the radial head fragment back into position. So other technique that has been described, which I don't have a personal experience with, is the Ashmark bandage technique, wherein a Ashmark bandage is wrapped from distal to proximal. And as you go proximally over the radial head fragment, it is gradually pushed back. Again, in this case, the elbow should be held in extension and pronation in order to achieve maximal success rate with this method. However, I have no personal experience with this technique. Then there are the minimally invasive techniques. So we have spoken about the close reduction techniques. However, if these fail, then we need to go ahead with minimally invasive techniques. And over here, I will mainly talk about two techniques.
तुम ना जब भी इसको बंद करते हो ध्यान रखा करो.
हेलो.
तुम्हें गाड़ी का लाइट जो है ना वो चालू कर. अभी तुम चालू करके ना देखना जरा बैटरी काम कर रही है.
रामन.
बैटरी.
Hello. So minimally invasive techniques over here, I'm going to mainly describe two techniques. One is the percutaneous K-wire leverage, that is the Kapanji technique, and the other is the Metesue technique. So percutaneous leverage technique, this is a pretty elegant method in which a thick K-wire is inserted into the fracture gap from the posterolateral aspect, and the fracture is then levered back into the correct alignment. And then if fixation is needed, the same K-wire may then be advanced and used as a fixation device. Now, there are some technical points regarding this maneuver. One thing is, surgeons are often worried about the danger to the posterior intraosseous nerve while performing this technique. So the question is, how do you protect the posterior intraosseous nerve? However, it would be important to look at the anatomy of the PIN around the proximal radius and ulna to see how we can protect the PIN. So please understand that at the level of the radial neck, the posterior intraosseous nerve is on the anterior surface of the radius. It then distally, it crosses the lateral surface of the radial shaft only about 3 finger breadths below the radial neck. So at the level of the radial neck, the lateral and posterior surface of the radial shaft are reasonably safe. Additionally, so this is a cross-sectional view. Over here, you can see that this is the PIN, okay, and the PIN is along the anterolateral surface, right? This safe area, this safe zone, can be further increased if the forearm is pronated. So if the forearm is pronated, the PIN will further go anteriorly, and that will further increase your safe zone for insertion of K-wire. So the main tips over here are always insert the K-wire in the safe zone, that is along the posterolateral aspects. And once you have inserted your K-wire, if you want to do any further manipulation, always stay in contact with the bone. Don't try to blindly withdraw and again reinsert the K-wire. Once you are inserted and you are in contact with the proximal radial metaphysis or the radial head, stay in contact with the bone. So here are a few diagrammatic representation of this technique. So here is how the K-wire is inserted, and with this, the K-wire is fixed. So this is how you can prevent injury to the PIN with the Kapanji technique. Now coming to the Metesue technique, and the Metesue technique was again described, I think, in the early 80s. And what this technique makes use of the hockey stick tip of the tense nail in order to effect an reduction. However, this can be used only for partially displaced radial neck fractures. It cannot be used for completely displaced radial neck fractures. So coming to a bit of the technical details. So what are the implants that are used? So we used 10 nails. And how do you choose the 10 nails? So just as in any radius ulnar fracture, the 10 nail has to occupy about 70% of the canal diameter, which typically in a small child is either 2 or 2.5 mm 10 nail. Now, how do you bend it? So the bending is not like what we do for a radius ulnar shaft fracture. Here, you have to bend the tip to 30 degrees, about 1 centimeter from the tip. Okay, so the bending has to be about 30 degrees, 1 centimeter from the tip. And additionally, here you need a sharp tip. Okay, you don't want the hockey stick of the 10 nail, and therefore you have to cut the hockey stick tip obliquely so that you get a sharp tip. The reason for this is that you want the tip of the 10 nail to engage into and fix the radial head fragment, which is partially cartilaginous. So you need a sharp point. Some authors have even used a Elizarov K-wire instead of using the 10 nail. So that is another option that you can use. Just like the 10 nail, the Elizarov K-wire should be bent proximal to the tip, and it should be long enough to permit manipulation at the distal end of the radius. So this is how it is inserted. Standard entry point, either dorsal or lateral. If you are inserting lateral, care has to be taken to protect the superficial radial nerve. Then the 10 nail is advanced retrograde. As you approach the fracture site, the bend is then turned laterally. The radial head fragment is engaged. And once the radial head fragment is engaged, the nail is rotated medially so that the bend now points medially. So this is how you can effect a reduction. If reduction is difficult, it may be assisted. So you can combine the Kapandji technique and the Metesue technique in order to get a perfect reduction. So initial reduction can be with the Kapandji technique, and then you can use the 10 nail as a fixation method. Few more technical tips. So as mentioned earlier, many times what happens is that the radial shaft, it displaces, the distal fragment is displaced medially, and here you can insert a small hemostat along the dorsal surface of the radius in the interosseous space and push your radial metaphyseal fragment laterally so that you get a correct alignment. So here again is a diagrammatic representation of the same, the Metesue technique, right? So these are the minimally invasive techniques, and before going ahead with open reduction, you should always exhaust all your options available. That is, you should initially try all your closed reduction maneuvers. If those fail, try out your minimally invasive techniques, and only if all of these fail, then you should proceed with open reduction. And why I'm saying that? Because open reduction, it has been shown that the results are significantly inferior as compared to the closed reduction or minimally invasive techniques. The main problem is loss of range of motion, which can be due to AVN, which can be due to premature closure of the proximal radial physis. In fact, there are a few papers which have recommended that if angulation at the end of closed reduction is less than 45 degrees, then these fractures might as well be left alone rather than attempting a closed reduction. The reason being that open reduction has higher complication rate. If at all open reduction is required, what should be the technique? So you should go through the Anconius extensor carpi ulnaris interval, carefully preserve whatever periosteal attachments are there on the radial head fragment. If the fragment is stable after reduction, you may choose not to fix it. So fixation is not mandatory. And obviously the problems which are associated with open reduction are stiffness, AVN, growth errors, and overgrowth of the radial head. Now, these were the standard situations that we see, but let's now go on to a bit more advanced things, and we'll talk about the special situations over here. And I will discuss three main special situations. Number one is the fracture in the very young child, where your radial head fragment is still unossified. And so, this is an example, a child who is almost 4 years old. The radial head fragment is not yet ossified. And so these can be a diagnostic dilemma. The child comes with history of fall on the outstretched hand. There is significant swelling and tenderness around the elbow. However, the X-ray is apparently normal. And these fractures cannot be diagnosed unless you do special imaging. So special imaging can either be an ultrasonography or MRI. because here you have to visualize the cartilaginous radial head. And indeed, if you see do the MRI, you will be able to see the cartilaginous radial head fragment. So this, as we all know, this is one of the injuries which is listed under trash lesions. That is, the radiological appearance seemed harmless. I guess you all know about this, and I won't further elaborate on that. These are called trash because these are not diagnosed on X-rays. These require special imaging in order to be diagnosed. And the tip, the main point over here is, in order to visualize your reduction properly, it is necessary that you have to do an intraoperative arthrogram over there. The arthrogram helps you to delineate the radial head fragment more clearly and helps you to ensure that your reduction is anatomical. Next, we come to another fracture pattern, a very rare fracture pattern, that is the Jeffries type 2. So far, in the last 15-20 minutes, we have just been discussing about this fracture pattern where the radial head fragment is displaced laterally. So this is the fracture that we have been discussing. But what is this fracture? You can see the radial head fragment, it is almost posterior to the capital. Okay, so these two fracture patterns are obviously different, and this fracture, which is seen to the right, it is called the Jeffrey type 2 fracture. And you have to recognize how this fracture occurs. So this is not a simple fracture. It is a fracture dislocation. And what happens is, while reducing the dislocation, the radial head fragment, it stays behind, it remains behind, and it gets trapped behind the capitulum. So it is important that you have to recognize this injury pattern. These fractures are not amenable to close reduction by our standard close reduction maneuvers. That is, the methods which I described earlier, they are not applicable over here. If you try to do these close reduction maneuvers, you may land up with a situation like this. So this was a child, this was a child who had this Jeffrey type 2 fracture, who underwent close reduction elsewhere, and then presented to us about 2 months post-injury. And can you see what has happened over here? The radial head has flipped over. So the cartilaginous surface of the radial head is now facing the radial metaphysis, and this is the raw bony surface. Okay, so this is the danger. If you try to do our standard close reduction maneuvers with a Jeffrey type 2 fracture, you can land up with a flipped radial head. In this patient, we had no option. We had to offer her, radial head excision. So for these fractures, a specific type of close reduction maneuver has been described, wherein what you do is you try to recreate the elbow dislocation, and with a K wire, you push your radial head fragment back into position, and then you reduce. So this reduction maneuver may be tried in case of Jeffrey type 2 fracture. However, if this fails, then you may have to resort to open reduction. The third, rare fracture variant which I want to describe is the intra-articular radial head fracture. So this was another child, an 11-year-old boy, fallen outstretched hand, who presented to us. And as you can see, this child has sustained an intra-articular radial head fracture. Now, to the naked eye, the plain X-ray looks quite innocuous, and it may appear that this fracture can easily heal if casted in situ. However, you have to remember that if you do an MRI on this, what you will see is that the radial head, many times in this injury, it subluxates posteriorly. That is because this is a high impact injury. It results in disruption of annular ligament, and therefore the radial head loses its support and it tends to subluxate posteriorly. This has been very well documented in literature. So this is what we did in this case. We open reduced it and fixed it with a single screw, and then we repaired the annular ligament around the radial head fragment. And this fracture is very well documented again in literature. It is known that these fractures, though they look innocuous on X-ray, they have a posterior subluxation of the radial head, and if left alone, that is, if treated in situ, they result in very rapid progression to radiocapitular arthritis. So this has to be remembered in this fracture. So I will just wind up my talk now, and this is just one case example, and this was done before I was introduced to Moline's maneuver. I have not yet had a chance to try out that maneuver, but in this case what we basically did is we did the minimally invasive reduction by using the Kapanji technique. And then in order to fix it, we then used our Metizue tense nail. Okay, so this was what we did in this case. So with that, I will just wind up my talk over here. So in a nutshell, The most commonest are the Jeffrey type 1 injuries, and they should be managed initially by close reduction. If close reduction fails, proceed to minimally invasive techniques. If that too fails, then you can go over to open reduction. But open reduction should be a last resort. And of course, you have to identify the rare variants which I described. One another thing which I didn't cover in this talk is radial head fractures associated with other fractures. And these are very high velocity injuries. The most commonest associated fracture can be a fracture of the olecranon. And when you see this injury, you have to be aware that it has a high complication rate, high rates of stiffness, can result in cross synostosis, and can result in significant loss of pronosupination. So if you see a radial head fracture which is associated with more fractures, then you have to be vigilant. You have to counsel the parents beforehand and inform them about the risk of stiffness. So with that, I will end my talk. Moleen, over to you.
Yeah. So meet questions you can find out. And
so we have a question by Dr. Chintan, sir. The question is that, is there any problem with proximal physis when we use a Herbert screw fixation in the long term? There was this image.
Not that I'm aware of. I mean, the aim of the Herbert screw that it should be a very, either a 2.5 or even, narrower screw, and it should avoid the physis. I mean, the screw should be exactly intra-epiphyseal, like what we do for a medial malleolus fracture, basically. So that should be the aim. You should try to avoid the physis, but yes, that risk is always there because that injury, finally, it's a grade type 3 Salter-Harris injury. So these injuries are known to be associated with growth arrest. So that risk is there, but specifically related to the Herbert screw, if you try to avoid the physis, I think iatrogenic injury can be avoided.
which approach you use for arthrogram, Sandeep? Posterior or lateral?
Posterior. Lateral to the olecranon.
Can you just mention the technique and landmarks so fellows can be helped?
So the arthrogram, so this is the olecranon tip, right? And you can feel the radial head, the lateral epicondyle, and so you have to go just lateral to the olecranon. Okay, in the interspace there is a soft spot over there, and as you go in with your needle, you will feel the capsule. And as you insert your needle, you will feel a giveaway. So this is a very simple approach. There are no really important structures over there. You are directly onto the capsule, and so that's the approach I use. How about you?
Yeah, I use the same, the posterior approach, and the advice to fellows is like, if you have very hard endpoint, then many a times you may have to redirect your needle. So the trajectory should be nice enough. Otherwise, this dye would spread to the extra articular place and it would obscure your imaging.
Another thing is the dye should be diluted and insert very small quantity of the dye. Okay, yeah. Just about 0.5 ml. You just want to delineate the articular surface. You don't want the whole thing to become dark. Otherwise, if you inject too much dye, you can't visualize any of the details.
Moleen, can I add something?
Yes, please.
Yeah. Moleen, I have one or two things to add into this. One is that I have never used Elizra wires. I have used 9 inches K wires. And most of the times, because sometimes, Elizra wire comes in a very, very standard thickness of 1.8. Sometimes you may require a little thicker wire.
Okay.
I have used 9 inches K wires. They're easily available, especially in the younger children. Second thing which I wish to add and ask everybody is that all these Jeffries tools, I have tried my level best to do an intramedullary fixation. And most of the times they still remain unstable. Either you are piercing the cartilage or they remain unstable, especially the Salter-Harris type 1s. Where there is epiphyseal separation. So I have added a oblique pin from the head to the metaphysis. What is your experience apart from the intramedullary? I mean, a single wire is usually, I have never found it to be sufficient.
Yeah, so Sandeep, you want to take it, or I can answer this question because we have not understood the biomechanics of the radial head, a fractured radial head. If you know the ligamentotexis, when we supinate the forearm, we relax the annular ligament as well as radius and ulnar lateral collateral ligaments. Now, if we see these injuries have, the head is mostly posterolateral.
Yeah.
And so the posterolateral structures, we have to obliterate those recesses. In order to that, we have to pronate the forearm. The moment you pronate and flex, when you flex, you are obliterating posterior recess, and when you pronate, you are tightening the annular ligament as well as the lateral collateral ligament. So even if you put the metazu wire, I would suggest to immobilize in mid-prone.
Absolutely.
For last 5-7 years, I have not used metazu or intrafocal pinning because we could reduce all of them with our technique. And every week I receive one feedback from different doctors that we have used your technique and we have been successful. So whatever you do, try to immobilize in mid-prone. What I have seen that once I reduce it 100% with our technique, if I supinate, there will be a bit of translation. And then you think that your implant is not holding, but it's actually the rotation, whatever, there is a risk that if you use very sharp nail, the proximal saucer-shaped cartilage is actually very thin. I have seen many complications where the 10 nail has penetrated the joint, or there is some it has gone into the epiphysis, and still there is translation. So probably 10 nail brings the head fragment back, but we have to immobilize in a way that these ligaments get tensioned. The problem is with the fractures. I like to tell fellows that clinically we should be able to judge that this is an isolated radial neck fracture or it's an associated with the elbow dislocation. What I have found that the tenderness is only on the lateral joint line when it is an isolated fracture, but when it is a post spontaneously reduced dislocation, there is global tenderness and there is global swelling, mainly on the posterior side. So many times you can understand whether this is likely that post dislocation or isolated right from before you attempt reduction. And always try to extend elbow, that will produce dislocation if it was dislocated previously. And there you have to go for open reduction. So that's my take on that. The other thing is,
Malin, what I was trying to say is that sometimes I have found that even a single wire does not, because there is no structure attached to the radial head sometimes with these Jeffries type tools.
I agree.
So
when I
sometimes
do
a
open
single
reduction,
wire is actually not sufficient. So sometimes you require a second wire too.
Yeah, I agree with you. I have also experienced the people have done metazu saying that we can start early mobilization, but as you said, even intraoperatively, sometimes after metazu you see rotation, there is some translation, so you are not confident enough to start mobilization right away.
Agreed.
And so I have placed antegrade thin K wire from the cartilaginous non-articular part of the radial head and fixed with the medial metaphyseal cortex, and it becomes absolutely stable. The key, and we have kept these children immobilized for 3 weeks. Once you see soft callus, you can remove that wire. That needs another small under anesthesia procedure, but most of them improve in their range of motion if injury is not very severe. What is your take, Sandeep?
No, I think I'll agree, Malin, what you're saying.
So the stability of the reduction, I think, it varies from case to case. And I think a lot depends on what are the associated, whether there are, what is the velocity of injury and what are the surrounding soft tissues. So there have also been cases where you reduce it and the radial head gets, sandwiched between your metaphysis and the capitulum. And it is so stable that nothing else is required. I completely agree with you that immobilization should be in mid-prone. And so that is the first step in achieving stability. Second step, I would prefer to just put in the Metesue wire just as a stabilizing thing. I would not prefer to put the wire through the joint, because obvious, we are scared about that, pin tract infections or whatever, stiffness and all that. So that would be my second line, the Metesue wire. Mid-prone would be my first. And even after that, if it is very significantly unstable, which is a very unlikely situation, only then I would go for that wire through the radial head into the metaphysis. Yeah.
Right. So, if we have any further question, then we have two interesting cases. So Chintan, you can start sharing your screen, and meanwhile, if we have any question, we can take Meet. Just go through your chat box and inquire if there is any question. Chintan, are you with us?
Yes, I'm here. I'm just trying to share the screen.
And you can share your screen now.
Yeah, so there's one more question by Dr. Raman. What are the long-term results of less than 100% reduction in terms of range of motion for close reduction cases?
So this,
I don't think there are any
Sandeep.
studies available, but what we have noted on the basis of our, of the cases that we see, cases which present to us late or who have not been reduced adequately, any angulation, residual angulation more than 30 degrees is going to result in loss of pronosupination of variable degrees. Now, this loss of range of motion again depends on the degree of angulation, the degree of translation. Translation is something which has not really been quantified as to how much of translation is acceptable. The literature is not very clear on that as to how much translation. But translation, the more the translation, the more the angulation, there is definitely going to be some loss of range of pronosupination. Though I can't give you an exact degree, that this much degree of angulation is going to give to rise to this much loss of pronosupination. I think that is something which will need to be studied. Regarding the remodeling potential as well, it is not, literature is not very clear as to how much degree of angulation at what age it remodels. Like, these things have been very extensively studied for things like the distal radius or the radius on the shaft or the femur fracture, but we don't have too much data on that. So based on this, clinically, what I would recommend is that any angulation more than 30 degrees, you have to make an attempt to achieve anatomical reduction, and you should not stop at anything short of anatomical reduction. That may involve close reduction techniques, but if close reduction techniques fail, then minimally invasive techniques. And most of the cases with minimally invasive techniques in fresh fractures, you can achieve an anatomical reduction. You need not go ahead with open reduction in most of the cases, unless it is a Jeffrey 2 or something like an elbow fracture dislocation or something. Maureen, what do you think?
Yeah, it's same. I mean, we see some children we receive, and they have terminal restriction of supination that we see in suboptimally or even sometimes in anatomically reduced head also. So there, this restriction might be because of the fibrosis of the interosseous membrane or the ligaments or the type of injury, and not there is a paper from John Wedge which mentions that translation of more than 2 millimeter leads to cam effect and restriction of pronosupination, as we see in the hip. But now how you can judge or measure that translation, that's an issue. So we try to reduce it as anatomically as possible. Sometimes we see the angulation in a range of 30 degrees, and then we see that this will remodel. But if in acute stage, always try to align it anatomically, and lesser degree of angulation you can easily reduce. The thing, just you give pressure and pronate it and it will get reduced. So try to align anatomically, at least in acute situations. Yeah, any other?
Gaurav is asking what should be done for neglected. So that again is a question that we do face, and it's
neglected. I have
a paper by an author called Cironi, CERONI. You can look it up. It was a JPO paper, and they had described a percutaneous, insertion of a small osteotome, just like what you do in a distal radius. Also, it has been described. So just put a small osteotome into the fracture site, through the posterolateral aspect, break the callus, and with the same osteotome try to lever the radial head back into position. But it was just a case report of 2 cases. What I would say is that, if your angulation exceeds 30 degrees, then you should give an attempt at that, this technique. However, if it fails, I have no personal experience with the technique, but if it fails, then if your angulation is up to 45, I might probably leave it alone rather than opening up. That is on the basis of that open reduction paper, which was, which I quoted in my presentation. So if it is
Those,
less,
once we leave it and they keep on angulating more and they end up into cubitus valgus eventually. If it, so I had occasion of neglected dislocation, Jeffrey type 2,
oh,
I had to open it up and put it back as a spacer. I know that anyway it would get into AVN, but that became a fibrotic spacer and the child did not develop cubitus valgus at least. And he had reasonable range of motion. So, yeah.
we had that one case of flipped radial head, which I showed you, and she was absolutely stiff. So we had to go ahead with excision of that fragment and arthrolysis.
Okay. Yeah, Chintan, you can share your screen now. Try it. Can you
Sir,
share?
I'm facing difficulty to share the screen, so I'm sending my PPT to Gaurav.
नहीं अभी कर ले, मैंने वो किया है, multiple participants can
अच्छा,
share.
अच्छा, because I couldn't share earlier.
अभी try करना.
एक second.
ये कोई लफड़ा हो गया, मैं ऑर्थोटी वाले को प्राइमरी होस्ट बना दिया है, मैं घोस्ट बन गया.
Yeah, so I can now click the share screen, but I can't see my PPT screen on it. I'm just sharing the screen to or sharing my PPT with Gaurav, so should be
okay.
Or should I share it with you?
If we have any other case, I think we'll discuss that first and then take up Chintan's case.
Yeah. The Aakash, are you there? Aakash?
Monin, you have any experience with these intra-articular radial head fractures?
No, I haven't seen any. After I don't remember any.
In fact, I remember
there was one case and I fixed with I didn't screw a very small thin K wire I placed horizontally.
In fact, this case I had presented it at Nagpur Posicon.
Okay.
And all the panelists, they opined that this should be conserved. And Sheetal was the only one who then, pointed out that the problems with these fractures, and then we had a discussion on the literature related to it.
This is a nice paper of Waters, no trash. All the fellows should read.
And then Boston again, Bay and Waters again came up with the paper where they showed a series of patients who had treated conservatively and then landed up with complete degeneration within a period of 6 months.
Right, agree. Sheenam has a question. What is the approach of reduction, open reduction?
Yeah, so it is between the anconius and the extensor carpi ulnaris. So you feel your common extensor mass, just go behind it. There is a soft spot posterior to it. You will just encounter a few fibers of the anconius, which you can then, retract posteriorly. So you go in between that interval. That's a pretty easy approach, a standard approach to the radial head.
Is my screen visible?
Yeah.
Dr. Chintan, please go ahead. Dr. Chintan, are you there?
Oh, mute hai. Chintan, you are mute probably, right? Okay, you can just put the slideshow.
Yeah, so this is...
Chintan is here.
Yeah, can you hear me?
Yeah, but with some echoes, Chintan. So. गौरव उसको स्लाइड शो करेगा सब पीछे
फुल स्क्रीन कर दो.
हाँ
Okay. Hello. Can you hear me now?
Yes, yes.
Yeah. I had to log in from the phone because I could not unmute from the laptop. So that's why you could hear the echoes. So now
Yep.
I'm here to present two cases which were conservatively managed. Thanks to Molin sir and his technique, which I tried for the last few cases, and I shared my results with him as well. So the first case is a 9-year-old girl who had a fall on her left elbow. Uh, there was a radial head fracture which was displaced anterolaterally, and this had come to one of the orthopedic surgeons in the periphery, and he had done a CT scan to identify how the fragment was, where it was lying. So the CT scan showed that the fragment is lying bang like almost anterolaterally, more so in the anterior, on the anterior surface, as seen on the first image here of the CT scan. And it was a completely displaced and angulated fracture with almost 90 degrees angle parallel to the shaft. So Jude type 4. And he was not confident enough to do it. So he had referred the patient to me because he was like, how do you reduce anteriorly dislocated radial head? And then what I did was exactly what Molin sir has described in his paper, gave a full extension and full supination, gave a varus thrust. Then I did some milking here. I think milking is more or so required when the angle is quite high, so as to bring it from Jude 4 to a bit of to Jude 2 level, so as to get the reduction when we do flexion and pronation. So I did a bit of milking from the anterolateral surface initially to get the fragment a little aligned with the radial shaft. And exactly how it's described by Molin sir, I flexed, and while flexing, I pronated the forearm. And in complete pronation, I could see that the radial head just, and I could hear a click. So when this radial head got back in its place, there was a sudden jerk of the elbow in the last terminal flexion. And that's when we took the C-arm to see that the radial head was completely reduced. And then I checked whether the radial head was, in position in movements of flexion, extension, and pronation and mid pronation. So I could find that when I was going to mid prone, I could see it go a little more in a displaced position. So this I also discussed with Molin sir later on. So probably I thought it is more safer to not allow it to displace within the cast, and that's why I completely pronated it again so as to get full reduction again, and then cast it in full pronation. I would advise that mid prone is okay, provided you see it on C-arm in the mid prone position that it is not dislocating any further. So I had pronated in full pronation, like the full palm facing the other side. So this was for this case of a 9-year-old girl. So now the patient is almost 5 weeks post-op. I had seen the patient about 10 days back, which was 3.5 weeks. That is when the plaster was removed. And now, actually, I called the patient yesterday for follow-up so as to take a video of range of motion. And but the parents on the phone say that now she has full recovery. She started going to school, and probably they will come on Sunday when the school has a holiday. So once I get the follow-up range of motion, I'll share it on the group. But I couldn't just get it yesterday. So now she can do everything. Full motion is there. I still suspect there would be restriction of terminal 10 or 20 degrees. But yeah, I need to see the kit before I comment on that. Another case which was successfully reduced, closed, was this 8-year-old boy who had fallen on an outstretched hand. This is more so of a Jude 2 or 3. The angle is not that high. It is about 40 to 45 degrees. And again, this was yet a simpler case. I did not have to even do a milking or anything. As soon as I did the maneuver, so this was initially tried by casualty resident, ortho resident and casualty, where I see that the angle had increased a bit further and the displacement on the lateral side was much more than what was there initially. But still, it was not very high. So again, with the same maneuver, I could get the radial head reduced. And this was immobilized in mid-prone position. So yeah, so I have been very successful in treating this radial head fractures with Mollinson's technique. Probably last 4 or 5 cases I've done. These are the last 2 cases in the last 2 months, and both of them without any Matiuzu or without using any intrafocal KYS, I could do it. Initially, I used to use intrafocal KYS, especially for the ones of Jude 4 or Jude 3, but probably now I'll look forward to not using it anymore. But yeah, let's see.
Beautiful. Colin, just regarding case 1, okay, that was definitely more challenging than case 2. Here the radial head is anteriorly placed. Are there any modifications to your reduction techniques that you would recommend in this scenario?
When there is anterior displacement, no, we have to stretch the anterior capsule so that we can push this anterolateral fragment. So again, you extend the elbow, and the key thing is you see the radial head in profile. Now that profile can be not full supination, it can be a little bit more than full supination, and that is the position of extremity where child has fallen, So if you bring that in that profile and then you start giving varus, most of the time we mistake that we keep it in supination, then we start pushing on the radial head, which is explained in the earlier techniques. But again, this rotation, it will obliterate the lateral recess. It will not allow the radial head to go in. So the first thing is you see it in absolute profile, and then you extend. In this case, with extension, the capsule had pushed this a little bit in the position. And then the other problem is our thumb should be on the radial head. We should feel it clinically, and sometimes I have taken IITV images to see whether I am right on the radial head. Sometimes we are either anterior or posterior, so our pressure is not appropriate. And yeah, that reduces this dislocation. Mainly once you convert it from a Jude 4 to Jude 2, either it's a little anterior or posterior, the pronation makes the trick, and it brings this back.
Yeah.
So I have received cases from, say, Jain sent me one. I always said that if it is dislocation, that it might not work. And he said, then even in dislocation, this technique works. So once you do one case, and you will be confident enough that we don't need to put it.
Yeah.
And I have mentioned that in pronation, but as Chintan rightly said, the amount of pronation, like either it is mid-prone or a little bit more than mid-prone, that depends on your intra-operative reduction. So when you take from full pronation to mid-prone and you find some translation, then you give plaster in full pronation. There's no harm. The key thing is to get it reduced in that position, and the range of motion will improve to almost normal if their anatomic reduction is anatomic.
Yeah. Good. So can we quickly go to the last case?
So what is Dr. Meets?
Sir, if like in case 1, if it's necessary to keep it in full prone, so do we change the position after some time to mid prone, or do we just after 4-5 weeks do we just remove and start start mobilizing the patient? How do we approach this?
So basically the amount of immobilization for younger children less than 7 years, I have immobilized for only 3 weeks, and then you take the plaster off. And for older children, 4 weeks, not more than 4 weeks, because more immobilization may induce stiffness. And sometimes, you don't see a callus because in the neck radius, it is difficult to see very good amount of callus, but you take it, and then if you have doubts, then you can immobilize it, keep a sling on, but gradual range of motion should be started. So 3 to 4 weeks of immobilization is fine. And don't worry that if you immobilize in more pronation, then you will lose supination. Aisa nahi hota hai. Anatomic reduction is the key. Immobilize in whatever position where you achieve anatomic reduction.
Okay. Thank you, sir.
Yeah. So if Aakash is there,
Yes, sir. Aakash sir has joined the meeting.
Aakash share कर screen भाई. ये क्या है?
Aakash screen is shared, but Aakash, Dr. Aakash, can you start your slideshow and start your presentation?
Okay. So Sheenam, are you there, Sheenam?
Yes, sir.
Dr. Aakash has shared that case on the group, no?
Yes, sir.
So you can share the screen and Aakash will talk about it.
Akash will have to stop sharing.
Can you see my screen?
We can see the WhatsApp tab.
Yeah.
Hello, Aakash.
Okay.
Open the file.
No, now she will have to again unshare this and share the PPT.
So unshare and then share your screen with the PPT. Sheenam.
Okay.
First open the PPT and unshare.
अभी PPT तेरे desktop पे खोल करके.
Okay.
Yes, sir. Sure, sir. One minute, sir. Sir, can I try once?
Can you try? Now we can see Aakash. Yes.
Oh, okay, sir. Okay, sir.
Get full screen.
Yeah. So go to the slideshow thing. Yes.
Same.
But that slideshow had only 3 slides. Sheenam, can you share now? And Aakash will give the commentary about it.
Sheenam, kindly share your screen, please. Yes. Good morning, everyone. Am I audible?
Yes.
Today my case is a neglected radial neck fracture in 10 years old girl.
Next. So there is a history of trivial trauma. The parents told trivial trauma fall on outstretched hand while playing on the terrace before 2.5 months of presentation to us. Child living at Taluka place, treated with bandage and medicine initially. Initial x-rays, as said by parents, were inconclusive. Probably fracture was missed by someone. That was my perception. There was a history of gradually increasing swelling and pain along her left elbow. Thereafter, they went to bone center nearby, and some massage and movements along the left elbow was done. Next. Yeah. Complaint of pain and swelling and restricted movement persists. Then parents went to district place and orthopedic surgeon reviewed x-rays. And then orthopedic surgeon advised CT scan. Next. So this is a X-ray, initial X-ray of the child.
Yeah, so this, Sandeep, this looks like Jeffrey type 2 fracture, right?
Yes.
Sandeep bhai?
Yeah, it definitely looks like a Jeffrey type 2. Now, how old is it?
So this is a 2.5 months old.
2.5 months.
Yes, sir.
So I don't think, any close reduction maneuver is going to help in this case. Probably, I would go ahead with an open reduction.
Yeah,
so like,
what
Maureen had suggested, in one case of his, where he used a radial head as a spacer. We know that in this case also, in Jeffrey type 2, it is more likely that there are going to be no soft tissue attachments, which means that the radial head is probably going to be avascular necrotic. But nevertheless, we can use it like a spacer, and which would help to, preserve the lateral pillar of the elbow and prevent the elbow from going into a valgus alignment. So I would go ahead with a open reduction. However, obviously preoperative counseling and explaining the parents about the risk of stiffness. I'm sure he's already stiff. What is the range now?
Next. So then CT scan review. What we did was, there is a CT scan. Next. So what we did was, we did open reduction. Actually, we didn't went to a fracture site. We opened the fracture area by modified Caucus approach, and then fixation done with 2K wire.
Okay. So you did an open reduction basically by the Caucus approach.
Yes, sir. Yes, sir.
Fair enough.
These are intraoperative IIT pictures. Next. So the second one is the 15 days follow.
So your wires were buried inside, they were intra-articular.
Yes, sir. It's not actually, sir, intra-articular. It's just beside the radiocapital joint, sir.
Okay. So those are intra-articular, but not passing through the articular surface.
Yes,
That's
sir.
what you mean, yeah?
Yes,
Going to the edge of the radial head.
So here that some people, Aakash, they say that you should avoid this wire and put a Matezu wire from the bottom. But I have seen that the stability with one wire is very, very good. And sometimes Matezu, you are a bit worried that whether it is reduced. I mean,
yes, sir.
But as Sandeep said, if the sharp Matezu wire is there, you can avoid this stiffness which is induced by the tip of wires to the lateral capsule.
Yes, sir.
Yeah, what is the outcome? 6 months follow up.
6 months follow up.
Wire तुम 6 महीना रखा है?
Sir, we kept for 1 year, sir.
Wire should be removed after once you see the callus,
Yes, sir.
You could have removed them earlier also. Yeah.
Yes, sir. I was also, that was my previous plan, sir.
What is the range now? What is the 6 months range?
Next slide.
This is 6-month follow-up clinical pictures. The flexion is almost similar to opposite side. This is a restricted supination and pronation. Next.
Pronation is more limited, as you can. She needs to elevate the. She needs to do abduction too. That is, but that is acceptable and that is a good outcome.
Considering the nature of the injury, I feel this is
Yeah.
a fairly acceptable outcome. I mean, this was a bad injury to start with. Additionally, there was a 2.5 months delay. Considering that, this was a good outcome, I would say.
Yes, sir. Thanks. Next. There's a 1-year follow-up after implant removal. Actually, I didn't have implant with implant X-ray at the time of 1-year follow-up.
Surprisingly, there is not much signs of AVN, no?
Yes, sir.
So there must be some tag of vessels, Even though this radial head has remained out for 2 months, there is no, probably there's no AVN.
Next. These are 1-year follow-up clinical pictures. This is just
There's a
before,
good range of motion.
next. Kindly play the video, Sheenam.
Video might not play. Now, as Sandeep has to wash up for a case, that's nice.
It's a good, very good.
Good range of
It is
motion.
almost a complete movement opposite.
I think the moral of the story is never give up on children. I mean, that is the.
Yes, sir.
So, thank you, Sandeep, for your time. It was a wonderful lecture.
Thank you so much, Maulid. My pleasure.
And I'm going to talk about radial neck fractures in iFix. I'll borrow your slides.
Oh, sure. My pleasure.
Yeah.
So,
if there is any question, now.
Yeah, I will reply to them. Yeah, sure. Absolutely.
Any question, the meet will send you on your.
Absolutely. Absolutely.
You can answer them later.
Absolutely. Thank you so much. It was a pleasure being here.
Take care.
Yeah.
Thank you, sir.
See you next week with this lateral condyle non-unions. Dr. Vidisha Kulkarni will talk about it. Okay. Take care. Thank you, everyone. Thanks, Gaurav.
Thank you, sir.
Akash.
Thank you, sir.
આકલા હવે બરોબર શીખી લેવાનું છે વેબિનારમાં પાર્ટિસિપેટ ટાઈમ ના બગડવો જોઈએ આપણો.
Yes, sir. Yes, sir.
Yeah. Okay. But nice case and good outcome.
Yes, sir.
Thanks, Gaurav.
Thank you, Sheenam.
Thank you, sir. Thank you, sir.
So what new thing you all learned today in radial neck fracture? Gaurav bhai, what are your takeaways from?
सर मेरे को एक तो ये जो वायर को मतलब मेटाज यूज मैंने किया नहीं अभी तक, मेरे को अपॉर्चुनिटी नहीं मिली. अब जब हमारी टेक्निक आ गई उसके बाद अपॉर्चुनिटी मिलती नहीं है. तो उसमें मेरे को वो वायर को टिप से बेंड करने वाला पॉइंट नहीं पता था कि हमें कहाँ से एग्जैक्टली बेंड करना है, और वो जो कट करना है वो मतलब
वो कट करना है ना, वो दो धारी तलवार जैसा है. Sometimes you cut it, make it sharp, then it will penetrate the articular cartilage. And if you keep it blunt, तो वो engage नहीं करेगा, ऐसा भी हो सकता है. So I have few cases जिसमें किसी ने मेटाजो किया, वो अंदर घुस गया और वो डाला है फिर भी डिस्प्लेस हो गया. तो पता नहीं है, वो लोग करते हैं लेकिन अच्छा होता नहीं है ऐसे. Right. Chintan, what you learned today? So Sandeep gave a wide variety of cases, and that's very important. The stress lesion. So any elbow pain and trauma without normal X-ray is very painful condition, because sometimes on MRI also we are not able to recognize what's going on. But you need to ask for a very good cartilage sequences and a very good thin cuts in MRI. So not to miss any particular issue. Okay. Bye, Kaisar, and see you next week. Take care.
Bye.
Bye.
Bye. चलो आकाश મળીએ ભાઈ. બાય.
Yes, sir. Thank you, sir. Thank you, Sheenam.
मेरा तो यार तुमने पैसा नहीं दिया।